Good evening and welcome. On behalf of the Western Society of Periodontology, we're glad to have you joining us this evening for a webinar. We are recording this evening's session, and you all have been muted except for our panelists and speaker. If you have questions, please put them in the chat box. And we do have Ashley Alley with Noasis, who will be monitoring this chat and responding to questions or sharing them with Dr. Kim. This evening, we are very lucky to be joined by Dr. John Kim. He is a practicing periodontologist in North Carolina, and we are excited to have him sponsored by Noasis. And I will turn it over to you, Dr. Kim. Thanks.
Oh, thank you. And hello and good evening, everyone. I swear this is me that's on the screen here. That was me pre-COVID and pre-pandemic. And I always had spiky hair my whole life, but I'm letting the COVID hair rock out right now. Anyhow, I feel so honored and grateful to speak for the Western Society of Periodontology. Especially want to thank Matt, Ashley, and Noasis for this opportunity, as I'm excited about sharing my experience with this unique membrane. And on this Thursday evening, thank you so much for attending, as I hope what I share today is something that can help you in treating your patients beginning tomorrow. I thought that before I begin, I'd give a brief introduction of who I am. Here I am with my beautiful family. My wife, she's a dentist, more of a full-time mother. I met her at UNC when I was doing my periodontal residency. My two beautiful boys, I think one of them's reading and the other one may be watching this webinar. And then I have my mother there and my father and my dog, Chloe, both of my father and my dog, Chloe, who we dearly miss. And then my brother and his beautiful wife, who just got married about a year ago during the pandemic. I grew up in Virginia and I graduated from the University of Virginia in 1999 with a BA in biology. Afterwards, I was very fortunate to be able to attend Harvard School of Dental Medicine and got more of a medical background there, where we were able to do 2 years of medical school. Following, I did my periodontal residency at UNC at Chapel Hill under the guidance of Ray Williams, David Paquette, and the late Stephen Offenbacher. I've been in private practice for nearly 2 decades. Time flies, and here's my amazing team. It's not the most updated photo. Again, a lot of these photos are pre-COVID, but they are truly my family away from home at Rocky Mountain Periodontics Implant Center. I have the privilege of practicing with my very, very good friend, Dr. Harriet Arrington, who is also a fellow UNC Perio alumni. We're very fortunate to have a dedicated team that goes above and beyond to help each other out and allowing for us to deliver high quality care for our patients. Today's webinar will focus on the dental application of the Amnion-Chorion allograft. It's important to note that this allograft has been used throughout the medical field. And this is especially personal to me since I've had a medical scare myself, something which is quite common, I think, to many dentists, hygienists. It's nice to know that the Amnion-Chorion has been used in the field of spine surgery, as I've had chronic pain and spine issues since 2012, and I still have it now, but not as bad. Beyond the wonders of how guided bone regeneration can help our patients out, I found bone regeneration to be very personal. In 2012, I noticed some pain on my left scapula, numbness on my left fingertip. It got progressively worse, and I had pain on my left fingertips and forearm. I was fortunate that I did not have any motor deficiency, so I was able to practice still, but the pain on a daily basis was horrible, and it will really mess with your mind. I wanted to do anything but surgery, go figure, as a periodontist, because number one, my fear, and number two, I just didn't know how I was going to be able to miss that time at work. So I proceeded with 3 years of physical therapy and finally succumbed to having the foraminotomy done. Unfortunately, I had no resolution 1 year later, so I went on with my second spine surgery. And this time, instead of the posterior approach, I went in anteriorly, or they went in anteriorly, and removed 2 discs at the C5, C6, C6, C7 level, and replaced it with artificial discs. I think they were from Zimmer Biomet, actually. Here you can see the end plates in place with the artificial disc in between. It's a very technique-sensitive procedure from what I have heard, and Some of my friends are neurosurgeons and orthopods, and they said that unfortunately it looked a little bit off center. My symptoms never got better. And now I have some osteolytic lesions in my spine. Prior to my third spinal surgery, which was to be a revision surgery to remove the hardware I had and convert it to an ACDF at 2 levels, this was quite a scary moment for me. I mean, I felt like this was my livelihood at stake. And I began to wonder if I could continue my career as a periodontist. Would I be doing what I'm doing tonight on a daily basis? If I could be a fun dad for my kids, and if my wife is going to be the one stuck taking care of me. It was quite a scary time. But thankfully, I had the world famous Dr. Daniel Rue, who works on a lot of celebrities and athletes, remove the artificial discs I had and the end plates, which you could see here. And here are my allografts that were infused with BMP in place with a 2-level fusion. Now, why do I share this? Proper ergonomics and learning to pace yourself is very important. And like many of our patients, I'm certainly hoping that the regenerative process is a smooth healing process for my spine. So on to tonight's topic. What is BioXclude? It is a dehydrated human de-epithelialized Amnion-Chorion membrane, sometimes seen as DDACM. This membrane is especially unique as it is considered a bioactive barrier membrane with biological advantages that could facilitate and accelerate healing. This therefore allows for this one unique product to have many different clinical applications. And this is a very good reason for Snoasis to have a happy face on the membrane. It makes all the sense to me in the world. Due to its highly documented success, as you can imagine, there are now other similar membranes available in the market. It's a copycat league, and I find that imitation is often the best form of flattery. However, it's important to know that BioXclude is the only de-epithelialized Amnion-Chorion barrier membrane in the dental market. As a disclosure, I want you to know that I use several different barrier membranes, and I think that you should still do the same. As each problem is very unique, it's going to have a different solution. We should all practice evidence-based dentistry. In general, I tend to be very skeptical of new biomaterials in the market, as honestly, I have not used any other biomaterials or dental implants other than what I have trained with in residency nearly 2 decades ago. So BioXclude is relatively new to me, though it has been in the dental market for some time. I believe it's been around for about a decade. I would see this, and my natural inclination is to question things. Immunoprivilege, anti-inflammatory, antibacterial, accelerated healing. I mean, it sounds too good to be true for a barrier membrane to have all these properties. Is this just, clever advertising? But seeing is believing. And when I saw what some of my friends and colleagues, what they were accomplishing with BioXclude, I stepped outside my comfort zone and decided to try a new product. It's all about making sure we are able to provide what can be best for our patient care. The beauty of BioXclude is that not only is it a barrier membrane, but it is also a carrier of all these growth factors, cytokines, chemokines rolled into one product. Before we talk about BioXclude, let's talk about Amnion-Chorion and do a quick overview. The amniotic sac is a tough but thin, transparent pair of membranes which holds a developing embryo and later a fetus. You have the amnion, okay, which is highlighted in light blue, and it is a layer of the placental membrane closest to fetus. And then you got the chorion there, which is in the darker blue, which is in the layer closest to the mother. Only half of this is highlighted because that is where the donor or donation is taken from. To allay any patient concerns, they should be notified that all donor tissues are from pre-screen elective C-sections in the US only. And if you would like to have a readily available pamphlet to give to your patients regarding the procurement process, just contact Synesis and they can get it to you pretty quickly. And if we are to zoom in on this from the previous slide, go in a little bit closer and take a look at this, you can see that the Amnion-Chorion is composed of various sublayers. Each sublayer is composed of different collagen types, which are primarily type 1 and 3, as well as other extracellular molecules. You can also see here that the Amnion and Chorion both have its own basement membrane, which is critical to allow the amniotic sac to serve as a true functional barrier between the mother and the developing fetus throughout pregnancy. Well, how can we take advantage of the inherent biological properties of the amniotic sac? And it's with the patented Periodon processing. And with this, first, the spongy intermediate layer between the amnion and chorion layer is removed. The epithelial is then removed, thereby exposing the basement membrane. And this is why there is no orientation and why BioXclude may be folded onto itself. In addition, the exposed laminin can hasten cellular migration, which helps the accelerated early healing. So through this whole unique process, the amnion and chorion layers are then laminated together, and voila, there we have our BioXclude. With the epithelial layer removed, the basement membrane is exposed and acts as a natural substrate for the epithelial cells, which in turn, during our procedures, especially when the membrane is exposed, allows for the acceleration of epithelialization and faster early healing. The proprietary Periodon processing helps retain all these growth factors, chemokines, and cytokines that are found in the native tissue, what is critical in the processing is specific such that the biological factors are retained and bioactive and not inert. Otherwise, how can we truly appreciate the unique bioactive properties of BioXclude? Now let's focus on the concentrated growth factors looking at this. This is the beauty of BioXclude, is that it has a sustained release of growth factors. Let's take a look at this chart here showing a few of the common growth factors. In the gray on the left side of the screen, that is going to be the percentage of the soluble growth factors after the first 24 hours. Then in the red on the right, the percentage shown is what is retained in the extracellular matrix after 24 hours and will continue to release, slowly release over time as a membrane resorbs. And this is remarkable and truly unique to have this sustained, slow release of the growth factor over 8 to 12 weeks. Now, today's webinar will be heavily clinically based, as I am a wet-handed periodontist seeing a variety of cases on a daily basis. So with the remaining time I have in tonight's webinar, I am going to go over various clinical scenarios and how BioXclude has made a difference for me and my patients. With its versatility, this is truly a Swiss Army knife of membranes, mainly due to its excellent healing properties and handling properties. Let's start with the bread and butter of many of your practices, extraction site preservation. Atraumatic extraction was done with a flapless approach as a tooth was deemed non-restorable. Here's a video from my good friend, Matt Fine. He is known as @Fianodontics on Instagram and someone that I enjoy and have the privilege of doing webinars with. Anyhow, after elevating the flap about 1 to 2 millimeters with the elevator of your choice, what this does is allow you to have just enough access to tuck in the BioXclude. In this case, you'll see on the screen at some point, or if you have not already, the 12 by 12 being used. And then, you proceed like the way you do with any other extraction site preservation. Make sure that bone graft is placed in there. So back to my case here, the bone graft was placed, and we don't have enough time to go into the specifics, but it's important to consider what type of graft to use, cancellous or cortical. Do we use a combination? What's the size of the particle you're using? Whether the graft is mineralized, demineralized. All these properties are important to look into when choosing your bone graft. So here you can see an unhydrated BioXclude, and what you'll want to do is use a dry forceps, in placing the untrimmed BioXclude of your size choice over the graft. In the anterior is typically an 8x8 and the posterior 12x12 or 10x20, whatever you feel would be appropriate. The orientation during placement does not matter, and BioXclude may be placed up or down. As this was one of my very first BioXclude cases, I did raise a flap as I was just wanting to get used to the handling property. Often nowadays, when possible, I will keep this as a flapless approach and tuck in the membrane. So let's go over the technique. You'll want to first use a dry instrument, such as a forceps, to place and anchor the BioXclude. I'll then dip my periosteal elevator in sterile saline, and then use that wet periosteal elevator to help hydrate and gently tuck that BioXclude. The bone graft underneath will also help hydrate and adapt the BioXclude to the bone graft. If you want, you can add drops of sterile saline to speeden up the membrane hydration if needed. I do that sometimes. Could also have a damp gauze that can be used to help adapt the BioXclude over the underlying graft while absorbing if you have excess fluid. The BioXclude is well adapted here over the bone graft and extended onto the native bone. I did a variety of suturing techniques here with PTFE, probably overdid it. Had a horizontal mattress placed, 2 single interrupted in the papilla area, and also even put in a reverse figure 8 suture, which we'll talk about. Probably over sutured this, when in reality, this probably here alone would have been enough. It is the reverse figure 8 suture technique. And as I mentioned before, use a wetted instrument. I like to use a buser quite often. That works well for me, to tuck the edges of the BioXclude as necessary. And the BioXclude, they say, only needs to be tucked in 1 millimeter underneath the gingival margin. I put it 1 to 2, whatever I feel like would give it better retention. Now, there are many different suturing techniques, but what I just talked about is my favorite, and it's using the reverse inverted suturing method in a figure 8. It will nicely approximate the tissue over the membrane. You go from internal to external, and this really helps prevent pulling the BioXclude out of place by accidentally nicking it. And because you go from internal to external, you help fold down and pull the tissue inward and downward for a better membrane retention and an excellent seal. In the anterior, I often only need just 1 reverse figure 8 suture needed. In the posterior, you can do 1, but often I'm doing 2 of them. As for the choice of sutures, I know that PTFE has been recommended, and I do like it, but quite often myself, I do see myself using the glycolin suture. That's been good for me. And one thing I do know is that I will avoid using a chromic gut suture for BioXclude. Again, this is all very simple and predictable when using this suturing technique. Just very fascinating. What amazed me about BioXclude is that what I was seeing at the 1-week post-op. And like I said before, seeing is believing. And even with the membrane being intentionally exposed, I'm seeing the excellent and accelerated healing that my colleagues and friends were talking about. And here we are about 4 months out with good soft tissue closure and healing. When we can get good healing, and I'm going to try to even talk over myself here. I thought I had this off, but this makes it very easy for the implant surgery. Here you can see sufficient quality of bone, and equally important, good quality bone. Got good bone turnover, don't have any residual bone graft particles. And this makes the implant surgery very straightforward and simple when you have that good quality bone present. Now, this is not too much from what I just showed, except now, unfortunately, it's an implant that had to come out instead of a tooth. And instead of raising a flap, I kept the whole procedure flapless. As you get more used to the handling property of BioXclude, you'll see how the reverse figure 8 suturing can make your life easier. As opposed to the previous case I just showed, all I needed was just 1 suturing technique. Simple. Let's look at the 1 and 2 week post-op. We're near full closure, and in my opinion, some accelerated healing that you would expect with this bioactive membrane. Overall, the post-op instructions are not too much different than what you probably are already recommending for your patients for the various procedures you do in your office. However, when the BioXclude is exposed, like in an extraction site pres, and you don't want to advance that mucogingival junction, then you do have to modify your post-op instructions. As shown on this slide, your patients must not be taking any form of chlorhexidine. Why? In studies, chlorhexidine has been shown to inhibit fibroblast activity, which may counter the accelerated healing we desire with BioXclude. Why would we want to take away its advantage? I am not going to go into the details of these studies. You can easily access them on JPerio or other journals. And what you'll see are some studies showing how chlorhexidine can inhibit gingival fibroblast proliferation, and again, therefore affect wound healing. In addition, what chlorhexidine can do is that it does have this cationic charge and therefore binds to the protein in an exposed BioXclude membrane, thereby slowing down the cellular migration that normally would have been accelerated. Remember that these rules of avoiding chlorhexidine applies only when BioXclude membrane is left exposed. Fortunately, BioXclude is inherently antibacterial, so you don't have to be as concerned with an exposed membrane. Just as the chorion trophoblast layer plays a critical role in preventing infections reaching the fetus, the same can be said for this membrane in protecting our grafts. I believe that this is the only membrane in the market with a potent antimicrobial factor, again, something that's very unique. What you can appreciate from this slide here is the zone of inhibition around the disc of BioXclude. And it has been shown in multiple studies how antimicrobial BioXclude can be. Most of us are already familiar with the past principle for predictable bone regeneration, as reviewed by Wang and Boyapati in 2006. This is nothing new to us and nothing but simple biology. You need to have primary closure. We need to have a good blood supply with angiogenesis. We need to have space maintenance, which is provided by the barrier membrane and the graft itself. And we need to have stability of the regenerating bone underneath that membrane. These are some random screenshots I have taken from my Instagram account. And what you can see are a variety of ways I am trying to achieve space maintenance and also graft material stabilization, whether it is with stabilization sutures, tacks, fixation pins, tie mesh, custom tie mesh, form stable, self-supporting titanium reinforced PTFE. I am always trying to follow the past principles to achieve predictable regeneration. In the collage I just showed in the previous slide, you probably got a glimpse of some of the cases involving a titanium reinforced PTFE. For a while, this was a workhorse for larger rig augmentation procedures, as it is a self-supporting membrane that allows for predictable regeneration, which then allows for an easier implant surgery. But there is a big if. That is, we can get that predictable regeneration only if we can avoid the complications. Studies have shown a high incidence of premature membrane exposure, and I can tell you that I didn't believe this initially, but now from my personal experience, I do believe these studies to be true. In my private practice, I can't afford to have a complication rate of even 5%, let alone 30%. I live in a small town and word spreads quickly. It would kill my practice here. With the Amnion-Chorion allograft, I can promise you, though not every case is guaranteed to be a success, you're never going to have a complication like what you see here. This is one of my own cases here. And so I'm a little bit more conservative nowadays, just because I just want to do what I can to avoid complications and just be the best periodontist I can be by being predictable over time, not try to do any heroics. Well, if we can get a pass from a complication, why not be greedy and see how can we get an easier pass? Well, one way is to make life easier with stability or graft material stabilization. Though I do love the periosteal stabilizing suturing, I mean, I do it all the time. Sometimes it can be challenging because for me, I try to avoid raising vertical incisions. So when you do the periosteal stabilizing sutures without a vertical release, it gets challenging. And this is a benefit you can have with BioXclude, where all the rules that you may be accustomed to don't necessarily apply. With its different handling property, you can get that easier pass and not necessarily need stabilization sutures in all major GBR cases. Here's a case in which there is sufficient bone, but not in the right place. If we place the implant where the bone is, the implant's going to be far too lingual and very, very, very difficult, if not impossible, to restore. Therefore, a posterior ridge augmentation is indicated for implant therapy if we don't go with a bridge. I'm going to show you how I go about these surgeries. I do intramural penetrations. I know the literature is debatable on its benefits, but why not? It comes with low risk, and I always want a better blood supply, especially in the mandible. And one way to improve graft stabilization is with sticky bone. And like intramural penetrations, the literature is divided on its benefits. However, I will say that there is no debate on how much easier this can make your life. There's no floating particles. It's easy to mold the graft to the site of the defect. Grafting is much easier with sticky bone, and something that I think is especially important to use in BioXclude. That's my opinion. Something very important to note here is that the same rules that you may follow with other collagen membranes, and especially the titanium reinforced PTFE, for example, is that you will place the membrane first and then place the bone graft afterwards. That's not the case with BioXclude. Make sure that you place the bone graft first, have it in place, and then place that dry BioXclude over the graft. The graft itself will hydrate the membrane and literally suck it down. Here is just a refresher or summary on how to appropriately use BioXclude. You follow these simple rules. The procedure, you follow these, the procedure will be so much easier to you. And what that means is that there's less chairside time, which means that is easier for your patient. And personally, my neck, they will have less associated post-op discomfort, and hence a happier patient with a smile as big as what you can see on this membrane here. What I really have enjoyed with this particular membrane is how well the soft tissue heals and also how fast it heals. There's no denying this. You can particularly notice this more when you intentionally leave the membrane exposed for extraction site pres cases. 6 months out, I went in for the reentry surgery, and I was very pleased with the quality of the natural looking bone. You don't see any residual grafting particles that did not turn over. You can appreciate a clear and well-defined osteotomy site. Again, emphasizing good bone turnover from the GBR procedure using BioXclude. And because of this, I'm able to place this implant in a more restorable position for my dentist. Got the healing abutment in place, and I apologize for no follow-up on the crown. I really can't say much about this patient not coming in because I'm not the most compliant patient myself, shame on me, but it's really important. Impossible to get this busy doc back into the office. The reality of any therapy, whether it's in the dental or medical field, is that sometimes you'll get less than ideal healing, as no therapy can guarantee perfect outcomes all the time. Here you can see that there appears to be some voids on the CT scan. This is a case from our own office in which that it is apparent that the bone graft did not fully incorporate and turn over. So we are now left with a void, but with enough bone to place a dental implant with a simultaneous graft. The implant is placed in a desirable position, and when I am finding myself needing to do a regraft, I'm especially more inclined to go with a safer solution, something that BioXclude can provide as it's a very bioactive membrane rich in growth factors, okay? It gives me the peace of mind knowing that I'll have potential for improved and better healing. We also know that the Amnion-Chorion will not get rejected as it is immunoprivileged. As I showed earlier, you want to have the graft in place first, and then you place the BioXclude while it is dry using a dry forceps and let it suck down over the bone graft that is over the implant. Had a horizontal mattress to help minimize a flap tension at the flap margin. And then I also had some simple interrupted sutures with glycolin to get that primary closure. After about 3.5 months healing time, here we are at re-entry with bone fill where there were voids previously. And this is what I love about the Amnion-Chorion allograft is the ability to be able to turn around a less than ideal situation into a good one with great healing. Good soft tissue health, and the radiographs show good bone around the dental implant while in function with the final restoration. And we all have these cases in which the healing is less ideal than expected or what we hope for. And when this happens, I especially will want a way to right the wrong. This is not to say that this is only our fault. It's only the clinician's faults. There are many reasons coming from the host and local factors that can lead to the failure. You can have a patient that has, and please excuse my language, piss poor protoplasm. They could be a heavy smoker, uncontrolled diabetic. Whatever the reason is, I will want to have that peace of mind of having a barrier membrane that can offer biological advantages. And the unique and proprietary Purion processing maximizes the growth factors, allowing for 20 times the growth factor load over amnion only products produced with these standard processing methods. It's something to think about. Let's go on to another case that is similar, and this time not mine, as this case was referred to me due to an area that did not heal well from an extraction site preservation. On the CBCT, you can see that the area had been grafted, but the buccal still appears deficient, and the quality of the bone, it looks questionable to me. Upon flap reflection, you can see the defect, which extended to the mesial of number 14. So we have a periodontal defect, and then we got this defect that's on the ridge. It took me a long time to clean out this defect. And after thorough curetting, and irrigation, I felt safe enough to place an implant to save this patient from yet another surgery down the road. Primary stability was not hard to achieve in this case. And after removing the transfer mount from the implant, you can see the defect present, and it's a contained defect. You can also see that there is a buccal concavity present. I used a composite graft of allograft and xenograft, no autogenous in this case, because I'm trusting my barrier membrane. This bone graft also had minced PRF and sticky bone was created. I then draped the Amnion-Chorion membrane over the bone graft. This membrane has an excellent handling property and it requires no trimming. It doesn't matter if it folds upon itself, and it doesn't matter if it's hugging or touching the root. The Amnion-Chorion membrane is hard to see, but it is there. It looks like saran wrap to me, and it drapes. It really drapes well and adapts easily over the bone graft. And like you would with the collagen membrane, you want to make sure that the BioXclude is extending onto the native bone, like you could see in here. And after I did that, primary closure was obtained. 6 months out, I'm very encouraged with what I see on the CBCT. However, it is important to know that the radiographic bone may not always necessarily correspond to good bone clinically. There was actually an excess of bone, and I had to carefully remove the excess first with my handpiece. That's how I usually do it. And then with hand instrumentation, usually a back action hoe. This is a time where I do not mind going over on my time, a lot of time for my uncoverings. I'd rather have too much bone. So we obtained a good ridge augmentation on the buccal, and the bone filled in quite nicely around the implant. And also, let's not forget, it filled in nicely on the periodontal defect on the mesial number 14. I actually had to remove some of the bone on the mesial to allow for the healing abutment to fully seat. So what my takeaway from the past few cases I've shown is that when you have a patient that did not heal well initially, consider taking advantage of the biological properties of this membrane. The Amnion-Chorion membrane contains well over 200 soluble growth factors, which aid in healing, promote angiogenesis, all of which are big contributors and key regulators of wound healing and tissue repair. And let's not forget, we will now have a lesser chance of post-op infection due to its antimicrobial or antibacterial property. Let's shift gears here, okay? According to Mombelli, the prevalence of periimplantitis and periimplant mucositis is much higher than one may think. About 10% of implants had periimplantitis, and about 1/3 to 1/2 of implants had periimplant mucositis. These are staggering numbers, in my opinion, and to keep implant therapy popular, I'm hoping that we can get some improvement here. And if you look at this, as you would think, periimplantitis is more common in smokers. The take-home point from this slide is if you're going to provide implant therapy, you need to know how to manage the complications. And I'm going to show a complication at the very end. If you are placing enough implants, just be ready to deal with the potential complications, because they will eventually happen at some point in your career, and these will be your patients for the rest of your life. This is a case that was referred to me last year. In my nearly 20 years of clinical experience, I've yet to find a predictable therapy in treating this. However, truthfully speaking, I've had more success lately with BioXclude. And this is especially nice, as I believe that we can all agree that treating periimplantitis predictably is tough. You can see some light bleeding and some exudate on the facial of implant number 14. The palatal shows the same, and the PA confirms that there's bone loss, meaning that this is not just periimplant mucositis, this is periimplantitis. As expected, there was a lot of granulation tissue to remove, and it wasn't that hard to actually remove it. And but it can take a while to clean it all out, and the decontamination part is very critical. Okay, I will use my implant titanium tips on the neutron setting to clean around the contaminated implant threads and go over and over and over. Again, without a good decontamination, I don't think this would work out. You can see that the circumferential bone loss pattern around the implant, wanting to further clean this and decontaminate as much as possible. I'll go back in and use my titanium rotary brush or titanium bristle that had the titanium bristles on it. And you'll see the tips get frayed as you use this. And I go circumferentially around the implant over and over and over again. I'll then go ahead and follow up with my doxycycline. To make this doxycycline slurry, it's very simple. Just add saline to the doxy and stir it up. Place that doxy slurry onto the exposed implant threads, keep it there, and then irrigate it. Mix it with your bone graft if you like to. I'll then place my sticky bone for better graft containment. And here I am ready to place my BioXclude, but let's see, how do we place this BioXclude in this type of defect? I use 2 BioXclude membranes here, and I trimmed the larger one, okay? So I trimmed the larger one, and you can see here that I have the buccal and facial, and those are, I know I'm gonna place those obviously on the buccal and palatal of where the bone graft is. And then from the top membrane that's longer, okay, in dimension, where I cut it into 2 smaller thin rectangular strips is I'm going to use that to thread it in interproximally so I can make sure that I have the bone graft fully covered by the BioXclude. And again, much easier to use this type of handling property that's on this membrane to do this. Here you can see that all 4 membranes are nicely adapted and draped over the bone graft. And importantly, and it's very important to make sure it's well extended onto the native bone. Though the benefit with this Amnion-Chorion allograft is that it can be left exposed, don't leave it exposed in these cases. Try to get that tension-free primary closure. I mean, this is an upward battle here in trying to save and rescue this implant. 1 week out, soft tissue healing looks great. I even removed one of the sutures on the mesial of implant number 14. 14 months out, there is a healthier clinical appearance with lack of inflammation, no implant threads exposed. And let's look at this. There's a lack of deeper probing depths, confirming the healthier attachment for number 14. And the PA showing some evidence of radiographic bone fill. Is it up all the way? No, but I'm very happy with what I've gotten so far. Well, let's look at this three-dimensionally. I think this is very neat. I love looking at this. And this is a video of the CBCT. It's a 14-month follow-up. And you can see that there is good bone circling around all around that implant, okay? And where there was no bone, prior to the GBR procedure, which you can see on the left side of the screen. So we've gone from potentially losing this dental implant to now saving this implant and so far keeping it in a stable state. Here's a case I treated just a few weeks ago. And again, the same presentation. You can see some separation around implant 11. And this is after a failed LaPip with ND-YAG laser treatment a few weeks beforehand. Obviously, it didn't work. Upon full thickness flap reflection, you could appreciate a significant defect with bone loss around the whole implant. This is worse than the case I just showed you. And again, I took a lot of time to clean out that defect. I took a lot of time to decontaminate after all that granulation tissue was removed. And I did everything the same manner as I showed in the previous case. Once I felt like I cleaned it the best I could, I went ahead and felt comfortable placing the bone graft into the defect. And of course, around the exposed implant threads. I then placed a BioXclude over the bone graft on the facial and the palatal. And this time I decided to try something that I've never done before with BioXclude. That is to place the periosteal biting stabilizing suture, which you'll see in the white dotted line soon, okay? And I do this technique so many times that it's just become a little bit more second nature to me. But I did this because I wanted to see if I can get some better graft containment, because I feel like this is going to be a miracle to save this implant here. Given that BioXclude is not a form stable or self-supporting like a titanium reinforced PTFE, I'm depending on this suturing technique and the sticky bone concept for better graft stability under the membrane. Remember, pass. With a more shallow vestibular depth and the frenal pull, this was harder for me to obtain that tension-free primary closure. I really had to work at it. 1 week out, thankfully looking really great, and I left all the sutures in place. Well, let's look at it 3 weeks out. Almost all the resorbable sutures removed. Whatever I didn't remove, probably just leave in. And at this point, I feel comfortable, lightly just palpating around the soft tissue and just make sure that I couldn't express the exudate that I was able to do beforehand. And this is a unique advantage you have with BioXclude, is that it is, again, antibacterial. I'll say that over and over again, but it's an advantage you get with this membrane. Here's a 6 weeks post-op showing graft containment and giving us hope in maybe saving this implant. For those that follow me on Instagram, I will show you how this goes, whether it's good or bad. And this is what I got just last week. This is 2 months out. We got excellent tissue health, and you can see some keratinization on number 10 and 11 there, which is another benefit you can have with BioXclude. Going to shift gears to a big part of my private practice, and that is immediate implant therapy. Let's look at this draining fistula that led to this patient experiencing a foul taste and smell. Did a minimally invasive extraction to remove a fractured teeth here. And the pre-op CBCT showed some bone loss. And even before taking the tooth out, I did anticipate wanting to raise a flap to have a better access to the defect. Here is the fenestration, not too big, but here it is clinically. I knew I was going to run into that. The defect is well cleaned out. Try my best to make sure that there are no soft tissue remnants left behind. And like you have seen me do several times throughout tonight's presentation, I'm like a broken record. I'm going to get boring here. I'll place my sticky bone and I'll cover it with the BioXclude membrane. I'll even put some LPR over BioXclude and suture to get that tension-free flap closure around the implant healing abutment. And 3 months out, at least according to the CT I see here, including that 3D rendering, the bone loss and fenestration defect are no longer present. Soft tissue healing looks good clinically. And here we are about 3 weeks out from when this patient has gotten a provisional. It looks like we have excellent tissue health, and we went from a good situation to a better situation. I want it to be even a little bit better if possible, as we're trying to help mold the soft tissue with the temporaries in hopes of maybe getting more papilla fill between number 6 and 7. Now, though this is not an immediate implant case, this is similar in the sense that I am grafting the gap in this case here. Okay, during the planning process in the digital workflow, it is easy to notice a retained root tip and shown in the red arrow. The reason that in this case, you see the sleeves removed from the surgical guide, for those that do these guided surgeries, it's very hard to get good access in the posterior. It's hard to get that drill into the sleeve. So I usually just knock out that sleeve and just do it half guided and half freehand. Anyhow, when possible, when you do these surgeries, you know, if you feel like it's good quality bone that's underneath and not just graft particles that didn't turn over, try to collect some of that autogenous bone from the twist drill, and so you could use it. Here we have the implant in place, packed it in with a titanium instrument. And here I went ahead and placed the dry BioXclude using a dry forceps over the bone graft after the bone graft was placed. And then it just sucks down onto that bone graft in the native bone. Got great bone fill, which you can see at the uncovery or re-entry surgery. I apologize on the screen here. If you can see it, there's some water droplets you can see in the mirror here. The healing abutments are in place. Compared to the initial presentation on the far right of the screen, we can appreciate some good bone fill around the dental implant, and the PA appears as though some good bone fill on the radiograph. So I'm going to shift gears again. Implant therapy has been the bread and butter of my practice, especially in the past 10, 15 years. But I will say that I miss good old periods. We always must keep the mindset of trying to save teeth first and foremost. Here's a procedure in which a patient needed a crown lengthening for number 19. And in doing so, I thought that this would be a great opportunity to address the narrow infrabony defect on the mesial of 18. You can see that probe going right into it. The bone graft is packed into that narrow mesial defect and then covered with the Amnion-Chorion membrane. This is the beauty of this membrane, is that it's probably the easiest membrane for me to use interproximally. Okay, and you can see it here a little closer. You could fold it, and it doesn't matter if it's hugging the root or touching the adjacent roots. You're not going to harm anything there. Again, in tight quarters, tight spaces, this is where you could take advantage of the handling property. 5 months out, great tissue health, and the PA is showing good bone fill. Look at this. We're 1 year out. Okay, last one was with the temporary crown. Now we got the permanent crown in place. What do we look like? Well, there's no deep probing depths. There's no bleeding on probing. There's great tissue tone. And even better, we see that the bone fill is still there on number 18 and maturing. We have good bone turnover. And so to me, this is so far a success, and it makes me really feel good about saving teeth and providing GTR. Here's another period case, this time involving number 13, where you can see some BOP and exudate on the mesial. As you can imagine, by seeing the infrabony defect on the mesial and the PA, this probes deep, I think 8 millimeters or so. Upon full thickness flap reflection, you can see the defect wrap around the facial to the mesial palatal. Using a collagen membrane here for GTR is not impossible, but it's certainly, in my opinion, not going to be as easy to use as BioXclude. In my opinion, you have to use a larger BioXclude membrane to wrap around the bone graft and to include the interproximal components. So, don't go stingy here, use a larger one. Often, like you saw earlier in the peri-implantitis case, I'm cutting the BioXclude into pieces while it is dry. Don't do it while it's wet. Obtain primary closure, and just yesterday, I was able to check on my patient as he was in for a recall visit. And I did not probe the area. I'm not ready to do that yet, but the tissue tone looked great. I could not express any exudate with digital pressure. And the PA is showing some good bone fill so far. I'm pleased with the progress. Remember, this is early. We're only 4 months out. So I'm going to take one at 6 and then a year out. And I'm excited about sharing that someday. And yet here's another case in which I treated the lingual, the mandibular anterior. And due to the nature and pattern of bone loss, am I expecting regeneration of all the missing bone? No, I have to be realistic with my expectations here. But what I am hoping for at least to accomplish are to reduce pocketing and have less associated inflammation. What I love about what I am seeing here is, one, when you look at the 2 different photos and look carefully, look at the healthier tissue with the lack of inflammation. Okay, I think it's a night and day difference. 2, you may have to look a little closer for this, but look, what's really nice about this is that the increase in the height and the thickness of the keratinized tissue. And we all know how important keratinized tissue is. It's very noticeable. And it's nice to know that this patient now has an improved periodontal phenotype with more resistant KT. As I mentioned earlier, I'm not exclusive to one biomaterial. And often I will combine biomaterials if I feel like it could improve the predictability of the procedure. As the standard collagen membranes are not bioactive, why not incorporate an adjunct membrane such as BioXclude, with many known growth factors to enhance healing, especially in cases like this where you see a significant defect. It's hard to see in the photos here, but a good portion of that palatal bone the palatal bone is missing. And I wanted a collagen membrane with less memory, a little bit more stiff on the palatal in an attempt to rebuild that. With the graft built up to where I wanted it to be, I then placed the Amnion-Chorion over the graft and the collagen membrane. That was a little bit challenging because again, using this the collagen membrane with less memory, I had to push a little bit to get that down. But you could see, this was let me see. Sorry, I got primary closure right here. Oh, near it, I mean, but because I couldn't get the full primary closure, though you can leave this exposed, since it was a larger GBR procedure instead of just an extraction site preservation, I just wanted to feel a little bit more safe and have that PRF layered over the BioXclude. And looking at the healing 1 and 3 weeks out, we are very close to full closure, and I truly believe that this is on its way to some good healing. And though this is no indication or guarantee of success, I do like to take an intraop CBCT for implants and some of my larger GBR procedures just to show that everything is where it should be. Now, this is relatively new to me, the laminar bone sheet as a membrane. I grafted a ridge deficiency not too long ago of number 22 with my go-to sticky bone. I then placed the laminar bone sheet over the bone graft. In doing this, there's going to be some bone graft exposed to the soft tissue, okay? So what I like to do is get that barrier membrane effect with the BioXclude. Again, I can do this with a collagen membrane, but to me, it's just been more challenging in my hands. And so when I use this BioXclude, it drapes over easily and just sort of hugs and covers any of the voids. Moreover, I have the peace of mind of knowing that I have a bioactive membrane to give this graft the best chance of turning over the bone. A suture to get the tension-free primary closure that is necessary for larger ridgeogs. I'm sorry that I also don't have a long-term follow-up for this case to show, but I think that you can appreciate the accelerated soft tissue healing I often get. On a routine basis, when I'm using an Amnion-Chorion allograft, either alone or in conjunction with another biomaterial, I see this. Another very big part of my practice involves soft tissue grafting. Here's a case in which I did a split mouth study design in which each recession defect was treated differently. I did a coronally advanced flap only for number 3, connective tissue graft for number 5, that's right, and the BioXclude for number 6, coronally advanced flap with Amnion-Chorion for number 7. I began with a connective tissue graft using the pouch technique. Amnion-Chorion was applied to the root surface of number 7. And here we have our 8x8 BioXclude ready to go using a dry forceps. Using my dry forceps or cotton pliers and micro elevator, I was easily able to tuck it in, but only after I began suturing, okay, but not yet tying the knots. So I'll suture it first, but not tie the knots. Then I'll get that BioXclude tucked in because I don't want to nick it with one of my sutures. After I had the BioXclude where I want it to be, I'll then finally tie the suture. Same thing here. Now I'm currently advancing the tissue over to connective tissue graft for number 5. And there you have it, primary closure from 3 to 7 with the flap advance. 1 week post-op, and honestly, this irked me as I have not seen this before, and I'd love to know a little bit more about this if any of you can comment later on. No foul taste or smell, and I cannot express any exudate, so I just watched. I felt comfortable enough doing that. 3 weeks out, okay, number 6 is looking much better, right? Let's look at it 3 months out. All the sutures are removed, and I would say that the healing looks great overall. And this is where we were prior to treatment. Now, focusing on number 6, I would say we obtained full root coverage. And look at the keratinized tissue before and look at the keratinized tissue after the Amnion-Chorion graft. We definitely have an increase right there. So we got the root coverage and we got an increase in the keratinized tissue on the tooth where I use BioXclude for a soft tissue application. Everything you have seen up to this point have been surgical applications, but what about non-surgical applications? I'm very curious about all the current clinical trials out there. I don't know enough about them, but I know they're out there and some results are out. And I'm waiting to see how some of my cases will do. So this is something I really hope to incorporate in any future lectures or webinars. Above is what you see in one of my cases where I did a scaling root planing, and it's recommended that you soak it in an 8x8 saline for about 30 seconds prior to inserting the membrane into the pocket. To be honest, I didn't do that. Instead, I let it soak in the pocket and I tucked it in with my mini-me instrument. Any tunneling instrument or micro elevator will suffice, provided that you can handle and manipulate it the way you would like without tearing it and making sure you get it to the base of that pocket. Now, this is not a case of my own. And when I get my next sinus complications, I know that I will use BioXclude to help bail me out. I see my friends and colleagues quickly turn around a complication into a success. Here you can see a relatively large sinus perf, and I'm going to show a video that again is not mine. So thank you for sharing this, Noasis. And you'll want to get a dry BioXclude in place over the perforation. Make sure that the membrane extends at least 5 millimeters beyond the edge of perforation. Same principles of when you do the GBR, except for a little bit more, okay? And what you'll observe is that the BioXclude really sticks and seals around that perforation so nicely, as evidenced by being able to see the breathing pattern that mimics the moving Schneiderian membrane. And so you want to make sure that the BioXclude does hydrate on the Schneiderian membrane approximately 30 seconds prior to packing any of your grafting material. Okay, near the end. Let's be honest here. Managing complications is now a big part of our profession, and I will not go into all the reasons why. More and more of my referrals over the years have been similar to what I am about to show. Let's listen to hear what Morgan had to say here.
The plant bothers me, and I think that it sticks out a little bit too far, and I just don't like the general look of how it blends with the rest of my teeth.
You can appreciate the thin facial bone on the CT scan. I mean, clinically, I knew that was going to be the case because you can see the grayish hue clinically through the gingiva. Here's an occlusal view. And you can see after the crown was removed that the implant is not obviously in the ideal restorative position. It's far too facial. What I try to diagram here with this illustration is that this is probably where it should have been and what we always aim for as surgeons or dentists, anyone that places implants. Upon full thickness flap reflection, you can see the palatal deficiency on the bone, which made it harder for the surgeon to initially place the implant more palatal. If you don't have enough palatal bone to place the implant in a proper position, you must do one or both of the following: augment the palatal or tilt the implant more palatal and anticipate a perforation on the facial plate apically. Confirming what was on the CBCT and what we can see clinically, even without flap access, I knew that this would probably be a good time to go ahead and explant this. Using an explant kit, I was able to atraumatically reverse torque this implant out without ever having to resort to a more aggressive trephining procedure, which is a nightmare to do when you have tight spacing in a lateral incisor site. So here we have the implant being removed, very simple. Like I do with all my GBRs, intramural penetrations, decortication, get a good blood supply. And I did it on both the facial and the palatal. I'll briefly talk about this since it is a big part of my practice. And the whole idea behind this autologous blood-derived product, PRF, is that it could potentially promote better wound healing and regeneration through the release of growth factors and cytokines. Yeah, some of the literature say that the growth factors help recruit cells, inflammatory mediators, cytokines, and promote, better wound healing, regeneration. However, I'm not banking on that, and I will use this mainly for the sticky bone concept to enhance the working property of the bone graft, make my life easier. Grafted with my sticky bone and use an Amnion-Chorion, which contains biological factors that can aid in healing, promote angiogenesis, reduce inflammation. A huge plus of this membrane, again, as I mentioned earlier, is that it's so easy to use. I placed my LPRF over the membrane and obtained tension-free primary closure. The key here is to use resorbable sutures on the vertical releasing incisions. Otherwise, they may be a little hard to remove later. And so far, I'm happy with the way this procedure went. Dentist here provided me the old flipper, so I knew what the correct depth placement of the implant should be. And here we are looking at an occlusal view of where I placed the implant, better than what it was initially. There are no implant threads exposed, but I just didn't want to take a chance on a younger female to not have that adequate thickness. So I went ahead and put an ossifying scaffold over this. And here we are, and this is where we are now, with great soft tissue contours, okay? Nice, healthy, thick tissue, and able to turn a horrible situation into a much better situation. And I look forward to this being a nicer looking crown in the area. So I hope you enjoyed the cases I showed. As I was all over the place with a wide variety of clinical scenarios, I think you can truly appreciate the versatility of this Amnion-Chorion allograft known as BioXclude. And it has many great reasons to be the game changer it has been in my office, as you get a barrier and a carrier in one product. The beauty of this is that this is something you can easily incorporate into your office and have great success with over a small learning curve. Nothing I think I did was special. I'm an average periodontist, okay, and this should all be reproducible in your hands. Just know your biology, do evidence-based dentistry, and always have that goal of doing what is best for your patients, and everything will be fine. So what I'd like to do right now is really thank you for your time and staying up on this Thursday evening. If you have any questions, here's my contact. You could email me. I'll be honest, I'm not as good about responding on email. I just got a lot of junk mail. I'm very active on Instagram, so DMing me there is a good way to get in touch with me. And I often do, teaching is a passion of mine, so I'll share cases as much as possible. It's always about learning together. And I learn from many of you out there. And so I'm always open to talking to you anytime. And so I want to thank you, Snowasis, for this opportunity. I only do these type of webinars for companies that I have the utmost respect for. Not only a great product, but just even better people working for them. So I look forward to meeting or seeing a lot of you in person finally at the AAP. Thank you, thank you, thank you.
Thank you so much, Dr. Kim. We really enjoyed that this evening. And I don't see any questions in the question and answer or chat area, but I appreciate you having posted your contact information. If anyone wants to reach out to you directly, that's a great idea. And we look forward to meeting you at the AAP in November in Miami as well. And this session was recorded and will be available. And we will share it with you, Dr. Kim, so that you can share it with others on your team. I'll confirm that with Todd. And then we will be sending out the continuing education for those that qualified. Thank you so much and have a great evening. And we look forward to seeing you on a future Western Society of Periodontology webinar.
Adios. Yeah, if I get out here.